You will note that I am not listed as the lead author on this study. That's because Cassie did most of the work. But I have been involved throughout this study. It will have some mention of hearing, but it's going to focus primarily on the speech problems. So just by show of hands, how many of the families here, the child with 1p36, how many of them have a speech problem? That's what I thought. Pretty much, not necessarily all of them, but most of them. This has been a big concern, and we are going to be talking about that if I can figure out which buttons to push. There we go. Okay. I'm going to skip these first introduction things. Okay, so as you know, 1p36 is a common, relatively common chromosomal abnormality. And you heard a lot about the structure of the genes, so we won't go much into that. The clinical features here, there's a lot. We could make a longer list than this of things that might be seen. The ones that we're going to be focusing on for this is specifically hearing, feeding, and speech and language. So, okay. These are some of the kids. The way that I approach genetic studies and genetic syndromes is a little bit different than Dr. Scott. So he spends time in the laboratory and he gets to know with exquisite detail what the genes are doing and how they are doing it, and then he gets to put these changes into mice and see what that how that impacts their function. Some people do that with fruit flies, and I don't do any of that. I try to do, I don't know how many of you know who Piaget was, but he had the best job ever. He was a psychologist, and he got paid to go down to the park with a pad of paper and a pen and sit next to the playground and watch kids play. And he would sit there and write notes about the different kinds of interactions that they had and figure out what's the normal pattern. So I do something like that, except that it's in people who have something that is unusual. So something like a piece of a chromosome that's missing. And I try to then look at what's known about the pattern, figure out if there are any questions that haven't been asked, and then try to ask and answer those questions. So I've been coming to this meeting. I have patients of my own that I take care of with 1p36 deletion. And I look and say, well, what are the common problems, and have the questions about those problems been answered? So I tried to look up what are the speech problems with 1p36, and every paper says, and there are speech problems. And then I would look through and read and try to find out more, and it said there are speech problems. And that was it. And I said, well, there must be a better way to look at this. So we went through and started looking at some of the related things. There's some literature on hearing. So it's reported that more than half of the kids have a hearing deficit. In one study, I don't know how that name is pronounced, but the bottom study, 77% of the patients had hearing loss. So we said, okay, maybe that contributes to speech problems. We'll put that in a file for later. The next one is looking at speech and language, and we looked at the incidence. So there is at least one common reference that says 98% have absent or severely delayed speech. Battaglia reported absent expressive language of any kind in 75% of patients, and D'Angelo reported 100% with significantly delayed speech. So I read that and said, but that is not what I see in my clinic. So I thought maybe there's more that we need. The literature also has a big emphasis on the impact of speech delay on the kids and on the quality of their life and the quality of their relationships with other people, and that is highly influenced. So about 3 years ago, I got a phone call from a family, and their geneticist had gotten back the results and found a 1p36 deletion, and it wasn't somebody who had previous experience with 1p36, so they went and pulled the literature and they read about it, and they came in and they sat down and they said, and it looks like there's nothing we can do, so I'm very sorry. And the family called me. I don't know how exactly they tracked me down, but they got my phone number, they called me directly at my desk. And I spent about a half hour talking to them and getting outraged at what had been said. And that was when I first got the idea to try to do this, and then I got talked to, we pitch our projects to the graduate students once per year, and I usually have something to do with 1p36 that I present, and Cassie said, that sounds interesting, I'll do it. And we went from there. So we looked again for more things, and we found very little in the way of details about speech. How did the kids communicate? What's been tried as interventions? There just really isn't much out there. So our goal on this was to characterize the speech and communication abilities of the kids. And we're going to go through some stuff on what we did. First, we asked permission to do this and made sure that we weren't violating any ethical rules. And we then had to write a written consent, and people who attended this meeting last year signed those consents and agreed to participate and subject their children to the speech evaluations. We also got some patients locally from our population in Cincinnati, and then anybody else who was available in Cincinnati during the time that we were collecting this data, we would do the assessments. And I do want to point out that the speech therapists who helped us with this did this on a volunteer basis because they thought it was important, and we should be grateful for their willingness to jump in. So we did a pre-assessment survey. Parents filled out some forms and told us about their child's communication skills, and then we had speech therapists actually do, and they used a bunch of tools. So we measured verbal ability, which is the ability to say words, receptive language, which is the ability to understand what somebody says to you, expressive language, which is the ability to put together your thoughts and get other people to understand them. And that is, it overlaps, but it's to some extent independent from the verbal ability. Some kids can say things and not know what they mean, and some kids can't use words but can let you know what they mean very readily. So it's broken down to some extent. Intelligibility is when they say words, how understandable are they? Can they pronounce the words correctly, and can family members understand them? Can professionals who deal with speech and language problems and developmental disabilities understand them? And can people from the general population understand them? Are different levels of intelligibility. Pragmatics are how well can they work around a problem. So if you try to say something and the people that you're saying it to don't get it, pragmatics is the ability to rephrase it or say it louder or do something differently to get the message through. And then feeding is related to speech in that the same coordination, timing, the same motor skills and sensory skills are involved in both. So that was an overlap, and we said we'll do an assessment of some assessment of feeding as well. Since speech is very heavily involved, communication is a two-way thing. Being on the receiving end requires hearing, so a hearing assessment seemed like an appropriate thing to do. Speech characteristics were then going to be classified into age-appropriate, mildly delayed, up to severely delayed. And we had a whole list of different tests that we were going to do. And I'm not going to have time to go into each of these, but each of these tools has different strengths and weaknesses, and they are also normed for different ages. So what we did was, based on the child's age and communication ability, select tools that would be appropriate for characterizing that child's abilities, and then score them on those different tests. And if anybody wants the list of what these are, you can contact me. If you have questions about any of the specific tests, feel free to ask, and if I don't know the answer to your question, I know the speech pathologists and I can track that down. The analysis was going to be done with descriptive statistics, and then comparisons were done using the appropriate statistical tools. So what did we find? So we had 28 individuals that we were able to do these assessments on. 22 of them were female, 6 male. Most of them lived in the United States. One child was from Mexico. I guess the Canadians were not successfully recruited. This is the breakdown of ages. And again, we had a pretty good spread, although if you look at this, we were very light on older individuals with 1p36, with only one in the 16 to 17-year-old age range and nobody older than that. And we were light on the youngest end of the spectrum as well. So a little bit of limitation there. We felt like it was important to know if there were correlates. So did having epilepsy predict more of a speech problem than not having epilepsy, or any other kinds of problems? So we asked about a number of different things, and we didn't find any strong correlations, but we also used this list of, and there's another slide here showing some additional problems that were reported. And one of the ways that we use that information is how representative are the kids in our study to the kids with 1p36 in general. And what we found is that they fit really well. They look like, for the medical problems, they really look pretty much like what's been described in the literature. They seem to be representative of 1p36. So we didn't have a selected population that was going to outperform or underperform the expectations. All right. So speech and language assessment was done, and this is the first question we asked. Does your child speak? And the answer was that more than half of the kids in this study had some verbal ability. That is very different than 98% being nonverbal or 100% being nonverbal. So we already knew that we had something to say with the very first question. Now, the next thing is how many of them had completely normal, and what we found is that there was a big range, but none of the none of the 28 children had completely normal communication abilities. So this is how it broke down. And so the different colors, the lightest color is the most severe impairment. So for receptive language, so all of the kids in this study had abnormal receptive and abnormal expressive language abilities. But if you look, the receptive language abilities, you have a big spectrum. So you have an about equal spread for mild, moderate, and moderately severe and severe. If you look at the other graph for the expressive language, you have small numbers of kids who were mildly involved and a big chunk that have a significant limitation in their ability to express themselves. So that's another important finding that had been previously reported, but it's a very important thing to be aware of. So then we asked about kinds of speech problems. So we heard that earlier that apraxia is not an ideal term because that should mean that nothing in your mouth moves, but that's the term that's used. So we had suspected that apraxia was a part of the speech problem in 1p36, but we didn't have enough patients that we had assessed that we were able to say definitively that that was the case. Of the 28 patients, 9 of them were completely nonverbal, which doesn't mean they don't have apraxia. It means we can't assess them for apraxia. So the 9, we just can't use that assessment. Of the remaining 19 patients, 5 of them did not have the characteristics of apraxia, which is a difficulty in sequence of movements and timing of movements of the parts of the mouth that you use to say something. Apraxia is to some extent independent of what you think or what you want to say. It's the mechanics of being able to make the words. That means 14 of the patients did have characteristics of apraxia. Only 5 of them had previously been diagnosed with apraxia. The others had just simply been told that they had a speech delay. So at least 50% of the patients in this study had characteristics of apraxia. I suspect that many of the other 9 that we couldn't assess also have characteristics of apraxia. It's just the tools don't exist to be able to diagnose it without the ability to speak to some extent. Now, you may be wondering, why do we care if somebody has apraxia? The speech therapy for apraxia is quite different than the speech therapy for some other forms. For example, I was told by one of the speech pathologists that the ideal speech therapy for apraxia, because it takes a lot of repetition to reprogram the neural pathways so that you can get the fluid motions, so they said ideally we would have a half hour a day of individual speech therapy. And in school, if you get speech therapy through your school, a lot of times you're lucky to get a half hour every 2 weeks of individual speech therapy. So there's a disconnect there. We need to know what the needs are so that we can advocate for the more intensive therapy. And some of the other details of the kind of therapy, the things they do to promote the development of the appropriate coordination, are different for kids with apraxia versus other kinds of speech problems. We also looked at intelligibility. So high levels, normal intelligibility with the words that were said was found to be in only 2 of the patients. And others all had some degree, and that goes along with apraxia. Kids with apraxia a lot of times will leave off the beginning sound or the ending sound of a word. They may also mix up some of the syllables if they try to speak in multiple syllables, either by using sentences or by putting longer words together. Then the next thing we asked was, well, they have a lot of trouble speaking. How else do these kids communicate? And as you can see, there were a number of different tools. We have gestures, sign language, PECS, which is a picture-based system, iPads, and then other electronic devices. And these were not, if you add up those numbers, it adds up to more than were in the study, but that's because people use more than one method. And to me, it doesn't matter which method, it matters that the kids can communicate. So a lot of the kids used multiple methods. Most of the kids in this study had clear, meaningful communication abilities. And that is in contrast to the previous studies where the majority were thought to have very limited or absent abilities to communicate. Feeding concerns. Now this one was a little bit confusing because some people answered whether they'd ever had feeding concerns. Some people answered whether they had current feeding concerns. So this is not an ideal answer on this, but the bottom line is a lot of the kids seem to have some difficulties with feeding. And we probably should do another study specifically looking at feeding issues. That one, I think it would be difficult to do at this meeting because we would need some equipment like X-ray machines that are hard to port around. But feeding and chewing, swallowing, discoordination were quite common in this population, although many of the patients were able to eat orally and fed fine. Hearing problems. This is another one where the results of this study really question the dogma. So the hearing problems are still common, but we have almost the opposite ratio to what was in the literature. 68% of the kids that we screened normal for their hearing, which means the hearing is not the main problem in the speech. It is still something we have to pay attention to, and if a child has a hearing problem, they need interventions because that will interfere with communication, but we do not think that it's safe to assume that most of the kids are going to have a hearing problem and that is why their speech is delayed. Pragmatics. The kids showed some reasonable pragmatic skills, although as you can see, many of the kids did have difficulty with pragmatics. And I'm not going to go into the details of that because, quite honestly, I don't know enough about the way speech therapists assess pragmatics to be able to go into all of the details. So what's the importance of what we learned here? So one of the things is that the majority of the kids had enough communication skills that they do have meaningful relationships and that we should have hope for them and we should be aggressively intervening. A rule that I try to teach all of the residents that I work with is that even if you don't know what you're going to do about it, if you can define the problem, that will in some ways improve the outcome. So simply by saying we know what the problem is here, we can do some very basic things that will make a difference. One of them is have conversations with your kids. And there are specific ways that you can change the kinds of interactions that you have with your child that will motivate them using principles similar to the talk that was right before lunch. You make it a game, They are motivated, and if you get them trying to communicate, that's going to improve the outcomes. If we're telling people your child won't be able to communicate, that's the wrong message. So talk to your kids, play with them, communicate with them. Any kind of communication that they can participate in is worthwhile. So we did not find a proven statistically significant difference between receptive and expressive. However, receptive language skills were across the board better than expressive language. The reason that we didn't reach the statistical significance is that our sample size was too small and the age range that we were covering too large to be able to definitively prove that. So high prevalence of apraxia is an important finding that will probably change the approach to speech therapy for a lot of the kids. So again, get a formal speech evaluation, ask the speech therapist if they are familiar with apraxia, let them know that apraxia is common in kids with 1p36. And that should change the approach to what they're doing for your child if they're not already familiar with it and haven't already recognized that. A verbal communication was stronger than expected, but was not the only method of communication. Use what works. If your child relates better to sign or gesture or iPad, use it. I know one family that I work with, their child could use some sentences but would never put more than 3 or 4 words together. They handed her an iPhone for her birthday when she was 14, and she texted and started using jokes and talking about how cute boys were and things that typical teens do. And they had no idea that she was thinking about these things. Now, not everybody is going to be able to do that, and they did. She had been working on reading skills and on keyboard skills on a computer for a while before they handed her the iPhone, so that it wasn't completely out of the blue. Auditory evaluation, again, better hearing than had been expected, but hearing is still a significant issue. Feeding was pretty much consistent with other things, and so the limitations I've already mentioned. We had a small study and only one time point that we could evaluate. And future directions, we need to do larger studies. We need to do some interventional studies. So if we make a diagnosis of apraxia and we do the speech therapy that's the standard for apraxia, do the kids do better? We don't know that yet because we haven't done that study. Be a little bit of a challenge because this group is spread out all over the country to try to do something that takes longitudinal follow-up, but we can think about ways of getting that done. So I'll open it up for questions at this point if you have any.
I have a question. When do you pursue the speech therapy? At what age? Because I keep being told, wait till he's 2, he's still too young.
Yeah, that's wrong. I can only tell you my prejudice. If a child is having feeding problems, I start with speech therapy in the newborn period. And we have actually 4 speech therapists in Cincinnati at the Children's Hospital who what they do is speech therapy for infants. And it's primarily working on oromotor skills. Feeding is the main focus, but that's a really important area to work on because it's a pre-verbal skill. If a child eats well, and that isn't a concern, then I would get a formal speech therapy evaluation by 9 to 12 months. And if they don't have normal oromotor and pre-verbal skills, I would recommend starting speech therapy on the principle that it's much easier to play keep up than catch up. So that's my prejudice. Some of the answer to that depends on the availability and the level of expertise of the speech therapists. It also depends on insurance issues. Paying out of pocket for speech therapy is quite expensive, and the programs that are state-sponsored, the early intervention programs that have been mentioned a couple of times previously, are limited by the amount of money that the state provides. So a lot of times, the kind of intensive therapy that we would use for something like Apraxia is going to be outside of that, and insurance often caps you at something between 10 and 20 sessions per year, and that really puts a significant limit on what we can do. One of the things that I would recommend, if you have any of those restrictions to access, is get homework from your therapist. You know, you are going to talk to your child probably 20 times a day, and the speech therapist is going to spend probably no more than an hour a week. If the speech therapist can teach you how to elicit the things that they want to work on, you can make progress faster because you have more points of contact.
If you don't mind, what you just said about getting the homework, a lot of speech therapists do not want you in the room when they're doing therapy with their kid because they don't think the kid will respond as well. But I was insistent the whole way through, and being fortunate to be a stay-at-home mom, I went to speech therapy with him at least once a week all the way through because I was with him all the time. And so we did speech therapy at 9 o'clock at night whenever he was interested, because a lot of times when he saw the therapist, he wasn't interested, but I could follow up with what they were doing. A lot of times I just sat in the corner and just watched, and sometimes they didn't want me to do that, but I said, he's my kid. I have the right to be here.
I agree with you completely. If you are not able to be in the room with your kid, because some speech therapists just simply won't do it that way, I don't know that you should fire the speech therapist, but you should insist that they then explain to you things you can do at home, because they simply cannot provide enough points of contact and opportunities for stimulation that they're going to be able to make the difference that you need to make in your child's life. You need to learn how to elicit communication and what the skill is that you're working on and need to be paying attention to at the time in your child's life, whatever that stage is. So I absolutely agree with your comment.
We've been fortunate enough to have therapy. My son's almost 5, or he just turned 5, all but 4 months since he was diagnosed at 4.5 months, or 5.5 months. The therapy place that he goes to, I love all the therapists there, but they switched him from the main speech therapist to he's going 2 or 3 times a week, and he's seeing 2 or 3 different therapists there for speech, and the same one for PT, the same lady for OT. But he's doing, with speech, he's seeing 2 different people, and I know that they talk, and I don't have a problem with them both working with my son, but it seems that, I don't know, should I ask to have him seen only by one?
So that's a complicated question. Therapies are personality driven to some extent. So no matter how knowledgeable a therapist is, if they don't relate well to your child, they're not going to make progress with your child. And so asking to switch therapists or can I get somebody else, don't be shy about that if you see And if you see a plateau, sometimes just a change in who it is will help get past that. Working with two different therapists isn't a problem if your child relates well to and accepts the input from both of them, provided that they are not in conflict about what they want to do so that they are sabotaging each other, which it sounds like in the situation that you're in, that is not the case. So I don't think that it's a problem to have two different therapists as long as they speak to each other once in a while and talk to you about what their priorities are and what they're working on.
Hi, Justin is almost 2 years old now, and he's had speech therapy since he was probably 1 month or 2 months old. And they started off speech therapy with a lot of oromotor exercises. That we would have to put our finger in his mouth and do a lot of exercises. And she was saying that was to help with him eating. We now see a different speech therapist who doesn't do any oromotor exercises. She just focuses on feeding, and she said that it's not necessary to do oromotor anymore because he is starting to swallow and eat food. But I'm wondering if the first speech therapist had more of the right idea as far as the apraxia and the oromotor exercises. Is that something he should be doing even if he is eating? Or shouldn't he still do oromotor exercises or no? When we asked his current speech therapist, she was like, there's, I guess, different schools of thought between speech therapists, and some don't want to do the oromotor, some just focus on just eating.
Yeah. So if you think about it, where do typical kids get the oromotor stimulation that they need to learn to speak? And that comes from eating. So if they're doing the eating, that is oromotor stimulation. Now, would there be some supplemental benefit if you do oromotor stimulation in addition to the eating? That's controversial, and I don't know that there's enough evidence to make a declaration one way or the other. He has a feeding tube? Okay. Then I would still do oromotor stimulation because he's not going to get the skills that he needs to do any verbal expression. Plus, if he has the same oromotor skills that made him need the G-tube later, he's going to be still drooling, potentially, or aspirating. And by doing the stimulation, you can work on some of those things. So I guess I'm not fully in agreement with that speech therapist.
Hi, Scarlett's 8 years old, but my question is more with your experience of other kids either with the syndrome or syndromes later on with apraxia. Is there a particular method of communication that you've seen in research that's more recommended approach to use?
So there's a huge variability in outcomes with apraxia. If you have isolated apraxia, most of the kids can eventually learn to speak orally. But the kids with 1p36 don't have isolated apraxia, and they have varying other complicating factors. So I don't know that there's going to be one thing that works for everybody. The speech therapists that I work with and that I've talked to about this say you expose them to multiple different techniques of communication. You use verbal, you use gestures, you use formal sign language, you use computerized systems where you touch a screen and it says it for you, and whatever your child relates to and is interested in using, you run with it. And there used to be worry that if you took that kind of an approach, that the kids would not ever learn to speak. That if you learn sign language, you're going to somehow prevent them from learning to talk. It turns out that if you teach a child who's got apraxia or some other oromotor speech problem some signs, and they get the idea, wow, I can communicate, that they also notice that most people communicate by talking, and they get more interested in verbal speech, and they have more to say, they make more of an effort. Are you telling me I'm done? You can come up if you want to. So I guess what I would recommend is what's called a whole language approach, where you just try a lot of things, and the things that your child responds to, you keep working on, and the other things you emphasize less, especially if it's something that your child is just resistant to, that you look for alternative methods. Okay, my time's probably up anyway. Hopefully we will continue to be, I'll be around if you have questions for me, and I'll be part of the panel later, and we'll continue to have a great weekend.
Are you next?